All right. So, we're covering fluids and electrolytes. As I drink some fluids. It's water today, okay? It's water. We're not Coke Zeroing it today. We're having water. All right. Total body water. So, it's pretty impressive when you look at the different age groups and how much water we hold. You look at elderly, for example, it doesn't take much for them to become super dehydrated. So, maintaining fluids is important. The older you get, the more you'll notice you got to drink water all the time. When I was, in undergrad, what was water? High school, what was water? It was either soda or soda, basically. And so now that I've gotten older, I've noticed like I cannot have water out of arm's reach, essentially. Just part of it is drinking coffee as well, I'm sure. But yeah, you need water to be able to do all your regular functions in your body. If you lose too much water, you alter the percentage or the concentration of your electrolytes. So you can start to get abnormalities, okay? So yeah, drink water. If you feel thirsty, you're dehydrated. That's the easiest way to think about it. Okay? So, intracellular fluid is about 2/3 of our total body water. Osmolarity, so we're talking about the solute inside of the cells. And how does water cross the cell membrane? Osmosis. Remember, water follows solute. So, a couple different situations. So, isotonic, your cells are happy. You're at 0.9% sodium and you're consuming substances that have 0.9% sodium in them. So we're getting it in our diet, for example. Like I eat something that has salt on it and the water I'm drinking from my fridge has solute in it as well. You can't drink pure water. Okay? I remember there was like some genius floating around on like Facebook with a video ranting about they're putting stuff in our water so we drink more. They should just be giving us pure water. And bro, you're gonna die. If you do that, you're gonna die. That is the hypotonic situation. You're drinking pure water, and so the water follows the solute. Well, if inside of your cells is 0.9% sodium chloride and NaCl, and outside is 0, or you're pushing it down below the 0.9, by diluting it, the water will start to enter the cells. We don't have cell walls. Our cells lyse. Your neurons demyelinate, right? So your neuron, think paper towels, like a brand new thing of paper towels. The neuron is the tube in the center of the paper towels, okay? The little cardboard tube. The myelin sheath is the paper towel wrapped around it. It is a cell, and its cell membrane is flattened and then wrapped around your neurons. And this is the insulation for neurons. Well, what happens is when the water starts to enter the myelin cell, Schwann cell? I think it's called Schwann cell. It's like AP1. What happens is it starts to unravel itself. That's the unmyelination. It won't go back. And when that happens, people will drop dead. There was a case a few years back here in Georgia. It was a contest to win a vehicle. And the gimmick was you had to drink a gallon of water and then keep your hand on the vehicle. Last person to leave to go to the bathroom wins the vehicle. It was like some radio contest. Well, some lady was one of the last contestants and all of a sudden just dropped dead. And so what happened was somehow the water accumulated in her system, even though she was drinking, I would hope, bottled water or tap water or something, that she entered a hypotonic state. And so what happened was her neurons unmyelinated and she literally dropped dead. Right? Hypertonic, this is like you're at sea or you're dehydrated, okay? The cells shrink. We can come back from this. This isn't necessarily going to lead to cell death immediately. It is recoverable. The problem with drinking like seawater is the body goes, there's too much salt in here. Let's pump it out the kidneys, and guess who follows? Water. And so that's why like drinking seawater dehydrates you more than just not drinking anything at that point. And they're now saying the pull back out here. So we have a push. Where's my pen? Come on, pen. A push out, that's our hydrostatic pressure. A pull in, that's our capillary osmotic or oncotic pressure. And there's another pull now they're throwing in here, which is 3 millimeters of mercury of interstitial osmotic or oncotic pressure. There is solute out here pulling towards it. So in this situation, we had 25 for hydrostatic. Okay. We had, 30. Remembered wrong. Look, movie magic. It's correct. 25 for capillary or osmotic oncotic pressure. So we were at 5 millimeters of mercury moving out. Now they threw in, well, there's 3 millimeters of mercury here. So now the correct answer is 8 millimeters of mercury out of the blood vessel or into the interstitium. Okay? So that's that second question we were just answering. All right, so edema, this is why we get edema, part of it. We increase hydrostatic pressure too much. Blood volume is too high. Or there's an obstruction to increase hydrostatic pressure behind the obstruction. Or there's protein-rich fluid in the interstitium. Okay, it collects. Proteins can migrate out, and they should be drained in the lymphatics if the lymphatics are obstructed. So if you watch like My 600-Pound Life, they all have lymphedema. It's because of the excessive weight is smashing or crushing, occluding the lymphatics. They get lymphedema, and it's just fluid accumulating in there. The skin grows and grows and grows to accommodate because of all the high pressure. And eventually when they lose weight, they have these giant hanging parts, excess skin because of this lymphedema. Okay? So there's pitting and non-pitting edema, and really what that has to do with is if it's pitting edema, you typically talk about it's like increased hydrostatic pressure. So it'll push down and it'll flow. It'll slowly come back versus the non-pitting edema. That's because the protein's in there and that osmotic pull, it just doesn't let go of the water. Okay. And you'll notice you have pitting edema at the end of the day. You've been standing up, that kind of thing. Take your socks off, shoes off, whatever. And you'll see like indentations, and after a little bit it goes away. And that's just because of gravity. That's really the only reason that's happening. Okay? ADH, antidiuretic hormone, the hypothalamus is sensing osmolarity of our blood. If it sees the osmolarity is too high, we are dehydrated. Okay? Solute versus water is off. It will command the posterior pituitary to release ADH. So the hypothalamus makes ADH, posterior pituitary stores it, and will release it. When ADH is released, it acts on the kidneys to pull water back into us. So instead of letting water leave in the urine, we pull it back into us. So now we're putting water back in the bloodstream. So now we're shifting that osmolarity back to normal. We're diluting the bloodstream. On the other hand, when you look at blood pressure would go through the roof. You're going to hold on to all the water you consume, and your blood pressure would be through the roof. So that's actually a syndrome we'll look at, SIADH, syndrome of inappropriate ADH. Okay? So they can have like a pituitary tumor, or certain lung tumors can cause this as well. So balance is important. We'll look at a couple of hormones here that affect sodium. Okay, so aldosterone. Aldosterone increases the reabsorption of sodium. The kidneys are releasing renin, which stimulates this whole process. So renin is converted into angiotensinogen, angiotensin 1. And then in the lungs, we have angiotensin converting enzyme converting it into angiotensin 2. That acts on the adrenal gland to release aldosterone. Aldosterone tells the kidneys hold on to salt. If you hold on to salt, you hold on to water. Okay? AMP, that's the reverse, essentially. This is released when your heart, the right atria stretches too much and we need to get rid of water. So it basically turns off aldosterone and we get rid of water. Okay, lose sodium in the urine, get rid of water. You would release renin and aldosterone when your blood levels or the pressures are too low. AMP when blood pressure is too high. Okay. Here, this is renal artery stenosis. There's a choke point here. So here's the aorta, and we're supposed to flow through here, renal artery to kidneys. There's a choke point, meaning the pressure through here is weak. If the pressure here is weak, we activate in the kidneys the renin-angiotensin system. So usually what it is, you get like a healthy 25-year-old coming in with raging blood pressure. And there's no reason for it. They're healthy, not overweight, nothing. They don't smoke, drink, nothing. And so that's when you would image and potentially find this. Okay? And it's sudden onset for some reason. And what they would just do, they put a little stent in there, open it up, problem goes away. Okay? So hypernatremia. If you have too much sodium, what happens to blood plasma volume? If you eat too much salt, you hold on to water, blood plasma volume will increase. What happens to your blood pressure? If there's more in there, goes up. What effect would this have on the atrial stretch? Goes up. What hormone should be made by the atria? Atrial natriuretic peptide, AMP, because it doesn't it's saying there's too much. What effect would that hormone have? Cause us to stop making aldosterone and release pressure. Okay? Is aldosterone produced as a result of hypernatremia? No. It's the other way around. Is renin made as a result of hypernatremia? It can be. Okay? A little catch there. And so you're getting into the juxtaglomerular apparatus, the JGA, and when it sees too much sodium come through the kidneys, it can release renin and hopes to stimulate ADH and turn off the system and hold more water. Okay? Hyponatremia and hypernatremia causations, there's a bunch of different ones. Really just inappropriate either hydration or lack of hydration to the body, or overconsumption of sodium, or loss. Okay? So all these different reasons here. This last one, 5% dextrose and water infusion. So you're given an IV solution here. Hyponatremia or hypernatremia? Hypo, right? You're not giving any sodium. This is just sugar and water. And there are certain situations we do that. We need to. If they are hypernatremic, I don't want to give them normal saline. I'll give this to dilute their bloodstream and get them back to normal. And if we overshoot, you would cause hyponatremia. So when certain drugs, they have to be put in certain different IV bags, you can get into these situations where you could potentially cause a hyponatremia if you're given the drug too fast because what you have to administer the drug in. So sometimes they will, deliver the drug differently, or they'll just do a quick push, or, pharmacy world. Okay? That's pharmacy people stuff. All right, potassium balance. So hypokalemia. The problem here is in the kidneys, they're antiporters. In your cells, they are symporters, meaning they travel the same way. Okay? So if you have too much hydrogen in your bloodstream, you're acidotic, you'll secrete hydrogen. You'll pull in potassium. Okay? And vice versa. All right. So with this, because potassium is needed for basic repolarization, relaxation of neurons, if they have low potassium, they can't repolarize. They can't go back to resting state. So this, can cause issues like heart, arrhythmia, stuff like that. Muscles don't want to relax, they twitch. That can be a causation. And a lot of people are like, well, yeah, you have hypokalemia, you got to eat banana. Bro, if you have hypokalemia, you're in the hospital, okay? In reality, you're probably dehydrated. That's probably what it is. And so when you're dehydrated, things go wacky, right? You get Charlie horses all the time. It could be magnesium. There's all kinds of different things. All right, do some blood work. Find out that way. Don't guess. Hyperkalemia, the blood will become more basic. Acidic. It depends on the causation. It's going to be acidic. You talk about like in DKA, diabetic ketoacidosis. In that situation, they are acidotic and the potassium shifts out, and so they're in a hyperkalemia. Will aldosterone be made? Yes, because aldosterone, sodium and potassium are antiporters. If you pull in sodium, you get rid of potassium. So EKG, like I said, potassium will start to cause wonky things happening. So this is catastrophic down here. Okay, especially these last two. They can go into what's like torsades, so like sawtooth, VFib, all kinds of things. So potassium levels are important. So how can we cause alterations? It's like too much insulin. We drive it into the cells. Okay. Laxative abuse. We're losing it in stool. Kidney failure because we can't excrete it. It builds up. Okay. Burn, all that. All right. Calcium imbalance. So calcitonin and PTH control calcium levels in your bloodstream. Calcitonin tones down calcium levels. So it lowers it in the bloodstream, drives it into the bone. PTH does the opposite. It causes it to come out of the bone into the bloodstream to increase the levels. So if someone has a tumor where they're secreting too much PTH, we can see where there starts to get weak spots in the bone. Okay, where the arrow is pointing, you can see it just not calcified anymore. Acid-base disorders. So there are so many causations of acid-base disorders. Basically what's happening is we're not maintaining blood pH, and then the body is reacting and trying to correct for the issue. Okay? So the lungs or the kidney can regulate this. Either we can breathe out hydrogen ion by breathing faster, so that'll lower CO2 levels, or we can breathe slower, increase CO2 levels, and increase hydrogen ion, decreasing pH. So if they're in an alkalotic state, they're basic. Okay. The kidneys can secrete hydrogen ion if the acidity level is too high in the body, and the kidneys can reabsorb bicarb if there is too much acid in the body. Okay. All right. 36 for PCO2. So we're here. So this is a metabolic acidosis. Is there compensation? Are we below 40? Yes. The respiratory system is compensating. Okay. This is like a basic pathway that you need to learn. It goes beyond that. They can have like combined, like let's say they have kidney failure and they have lung failure. It could be both these numbers beat the category. So their bicarb could be below 24 and their PCO2 could be way above 40. So that's like a dual failure at that point. It's combined acidosis. But we're not doing all that. So a couple practice questions in here for you. Okay. On that, but not a big deal. So we're having alterations in the anions as well. And so it means they're like hyperchloric, chloremic metabolic acidosis usually is what it is. So mud piles is just the memory tool for a lot of the causation. So methanol you find in methanol you usually find in things that we don't want to freeze. So like winter windshield fluid. I don't know why that just sounded weird. It's like a little tongue twister. Okay. It's so it doesn't freeze. They'll put it in like mouthwash so that people won't drink it. You can find it in vanilla extract. You can find it in there so people don't drink it. Trying to think where else, if there's any other common. Basically, anytime they moonshine's the other big one. When they're generating alcohol, it generates methanol, and it's a byproduct. If they don't pour it off, you can cause this in patients, and it causes blindness as well. Okay. DKA, all these you can go through and look them up, but they're all causations. Ethylene glycol is your coolant in your car. Salicylates, this is aspirin. So when patients overdose on aspirin. Okay.